Mr. Elliott?
Yes, what I'm going to do, I'm just starting it on YouTube, and then I'll come back here, because otherwise, sorry. Are you getting now? Because otherwise, sorry, David.
Good evening from Canada.
Sorry. Are you getting now? Problem with the sound now. Hang on a minute. Because otherwise, sorry, David.
No problem at all.
Good evening from Canada.
Sorry. Are you getting now? Problem with the sound now. Hang on a minute. Because otherwise, sorry, David.
No problem at all.
Good evening from Canada.
Sorry.
Okay. Carlos, you're on mute, but are you happy for us to start? So good evening, everybody. This evening we have the pleasure of Mr. David Elliott to give a talk to us on avoiding poor results in flexor tendon surgery. So Mr. David Elliott is a recently retired consultant from the Broomfield Hospital in Chelmsford, where he served as a consultant plastic and hand surgeon for over 30 years. I'm sure we don't need to remind ourselves of all the achievements of Mr. Elliott, but I will summarize some of them for you this evening. He is a author of over 120 publications in the field of plastic and hand surgery. He's been a true pioneer and has improved our current practice and knowledge of many of the common hand pathologies. David is a past president of the British Society of Surgery of the Hand and a past editor of the European Journal of Hand Surgery, past examiner of the Diploma of the Hand Surgery for the Federation for the Surgery of the Hand, and a past chairman of the Flexor Tendon Committee of the International Federation of Society for the Surgery of the Hand. So without further ado, we will now start our lecture. Thank you.
Good evening, ladies and gentlemen. Carlos asked me to discuss how to prevent poor results in primary flexor tendon surgery. I've turned the title round, as I think the best way to put this over to you is to consider the refinements of thinking on this subject over the last 30 years, as what we do at present is largely a product of these changes. All surgery can be considered as a series of dogmatic rules intended to achieve the best results given the knowledge of the day, with the understanding, of course, that these rules may evolve as our knowledge changes and hopefully improve, although we do sometimes go up blind alleys, as you'll see in due course. My training was in the dogma of the 1980s, and my consultant career spans the 30 years of this talk. Ignore the detail of this slide. The headings are the 5 parts of this subject we need to consider, and these were the dogmas of the 1980s. And this is where we are, or should be, in my opinion, today, and I'll discuss each of these boxes through the last 30 years. This was a famous saying, the hallmark of these Louisville men and their trainees who spread this mantra all around the world. This has now gone and been replaced by a belief that flexor tendons should not be done immediately at dead of night by inexperienced surgeons, but can wait 48 hours for treatment by a more experienced surgeon. If you like, a step back towards the Bunnell philosophy, which held sway from the 1920s to the 1950s, that primary flexor surgery should not be attempted by amateurs, and that the skin should be closed and the cases sent for delayed secondary surgery, effectively tendon grafting in most cases, by those who had sufficient experience. I'll come back in a moment to how Bonnell's teaching was blown away. But first, this Louisville philosophy was itself blown away by the realization that the workforce in Louisville, full of doyens of hand surgery, could provide tendon experience at all hours of the day and night. But elsewhere in the world, night flexor repairs would be carried out by young trainees, often not even plastic or orthopedic surgeons, and this is simply not good enough. Recently, Professor Tang in Shanghai has introduced the idea that papers on this subject should include a statement on the level of surgeons involved in the surgery, which is not only a logical addition to the audit process, but also an understanding of the realities that the techniques of tissue handling in this field are not learned in one sitting, but by many, many repeats of the process and guided by older surgeons. Our current management of immediate primary repair and immediate movement, albeit in protective splinting systems, started in the 1950s with these surgeons and a few others who challenged Bonnell's teaching by showing better results from primary surgery and immediate rehabilitation than by delayed secondary grafting surgery. This was such a revolution at the time that the American Hand Society sent Littler, one of its senior figures, to Louisville to report on what the young climate was doing. He returned with the message, "If I cut my flexors, send me to Louisville." And the basics of management as we know it was begun, with the intention of avoiding this problem of adhesions. To avoid this, we risk rupturing the repairs by moving them during the first 3 months, when the tendon is largely held together by our sewing efforts. And unfortunately, 3 months can be longer than a patient can keep his hand free of activities or accidents. It's worth considering here the human and economic consequences of rupture of the repair, reckoned for years to be about 5% in the best units in the world. Any argument about the cost of different sutures and splints that pales into insignificance compared with the cost in money, wasted medical time, loss of work, disability, etc., to the patient, surgical team, and to the state of the follow-on of a ruptured repair. So the hunt was already on back in 1989 for a zero rupture rate. In 1989, we all religiously repaired flexors with two-strand core sutures, albeit using increasingly sophisticated instruments as these became more available. And the instrumentation may be an unsung feature of improving tendon results. In 1999, I met Verdun on his 90th birthday, and he told me that his biggest jealousy of nowadays compared with his era was the sutures and instruments we now have. In the 1950s, he only had foro silk and large orthopedic instruments. These and slight modifications were the two-strand techniques being used in the 1980s, the Kirchmeier-Kessler in the West and the Sugi in the East. Both are two-strand core sutures, as one pass of the Sugi loop suture equals 2 strands. And both configurations grip the tendon, unlike the old Bonnell suture. Whatever suture material or suture technique was used, the results from the best units in the world always came out roughly with a 5% rupture rate. Urbaniak's classic paper on two-strand core sutures on dog flexor tendons shows why the suture material was relatively irrelevant. On day one, the various sutures the various Kessler sutures he was using had quite varied strength. By day 5, the tendon started softening, and the mechanism of failure changed from sutures snapping to sutures pulling out, and they all became equal. The suture material has not changed much over 30 years. Wire is stronger, but it's difficult to use, and neither it nor devices such as the Tenafix or barbed sutures have caught on, probably because none of them have been shown to be outstandingly better, and anything new is difficult technically for most of us. Suture size does matter, and this has been shown in vitro, and the Brunelli Mantero technique capitalizes on this. There's a limit to how big a suture, however, that one can put into the flexor tendons, as the knot inside the tendon gets bigger as the suture gets bigger. The Mantero technique takes the knot outside onto the end of the finger, but this technique is difficult to use except distally in the finger. Again, not much interest in this line of advance over the last 30 years, although this Mantero suture is a commonly used procedure mainly in Southern Europe with perfectly good results. So going back to the configuration, was the two-strand core suture good enough? Well, these published figures from my unit in 1993, in what was by far the biggest number of flexor repairs ever reported, show we were holding the 4 to 5% rupture rate at the time, albeit with a very skilled therapy department. And these figures from other units with a major interest in the subject all over the world show much the same. It was generally considered that the core suture strength needed for early mobilization was that for movement against moderate resistance. As you can see, the two-strand core suture just achieves this, but with little to spare. In 1992, Professor Schund in Belgium measured the forces on intact tendons at the wrist and the carpal tunnel. You can see that if we're to prevent ruptures in patients who break our rules and use the hand early after repair, then our sutures may need to resist far more than 15 newtons. In 1989, Mr. Savage in Newport, Wales, dropped one of his many bombs into the flexor world, following up on an earlier research paper which got little attention. He reported a small series using his 6-strand core suture with a rupture rate of 3%. To cut a long story short, this has spawned hundreds of papers, mostly laboratory studies, albeit occasional clinical audits, over the last 30 years, looking for the best configuration of 4 or 6-strand repair which would consistently achieve no ruptures. Rather than going into the detail of these many sutures, we need in 2020 to analyze the success of this massive amount of work. The 1990 surgeons, as you saw, were running at 5% ruptures. These are all the published papers from 2000 until 2011, and to me they illustrate 3 things. First, Belfast mobilization seems to have overtaken Kleinert rubber band traction. Second, possibly surprisingly, most units reporting results were still using 2-strand repairs. And third, the reports of 4- and 6-strand repairs, shown in green, show a possibility of improvement in the rupture rate. More recently, there are only a few more studies, but they do show an increase of 0 rupture rate with these large core sutures. Not perfect, but still improving. And I think we should all be putting in at least 4-strand core sutures, as there would seem to be no disadvantage to this relatively simple addition to our activity. And these are 2 of the many 4- and 6-strand sutures which I particularly like. I have a suspicion of continuous multi-strand sutures, as particularly if the sutures are locked as they pass through the tendons, there is no guarantee that all 4 or 6 strands are under the equal tension necessary for all of them to be functional under longitudinal stress. Both of these techniques avoid this problem, particularly if proline, not braided suture, is used, and both are relatively simple to put in. I think Tang's triple sui, in my opinion, is the simplest, and though the looped sutures are expensive, they don't come into the same cost bracket as a ruptured repair. However enthusiastic one is about these bigger core sutures, I think one has to be aware that the problem of tendon ruptures has not quite gone away. I'd draw your attention also to this study by Jason Wong from the McGrowther Laboratory in Manchester, which showed that tenocytes move away from sutures put into tendons. This suggests that putting ever more foreign material inside the tendons may have its problems. I also want to take you back to the beginning of this tale again and look more closely at the results of these 3 studies. They show 3 different suturing methods with very little difference in rupture rate. In a talk given a few years ago in Sicily, Savage reviewed all of the Flexor studies since his own in 1989. His rupture rate with a 6-strand core suture in 31 zone 2 fingers at 3% was the lowest. However, next best was our 4% with a 2-strand suture in 397 zone 2 fingers. Given the difference in the number of fingers between the two studies, to me these numbers say no difference in rupture rate. So I think perhaps, as well as going down the road of more strands of core suturing, we should retain an open mind as to whether other factors have importance too. The circumferential suture was originally introduced in Louisville to smooth down loose ends and improve gliding of the repair. Then Mr. Wade in Coventry in England showed that it had considerable strength in itself, which may explain why the many 2-strand repairs did so well in the 1990s, as all of them had this tidying stitch, lifting the strength by an extra 20 newtons from 15 to 35 newtons. Following Wade, various configurations of circumferential suture were developed, and some of them were as strong as the core sutures. Mansky's team in the United States found much the same. So we now had another technique, either instead of the core suture or to augment it. However, the Kubota study also showed that the more material there is on the surface of the tendon, the more friction there is on mobilization. So historically, as the strength of the core sutures increased, focus went off these elaborate circumferential sutures, which were technically much more difficult to put in. And at the turn of this century, we mostly returned to a simple running circumferential suture. And recently, with very strong core sutures, Thomas Giesen in Switzerland has abandoned this addition. Although I personally still think it's useful for its tidying function to help gliding, plus it adds a little bit more strength. By the 1980s, immediate mobilization was well established as a second part of the mechanical way to stop adhesion formation, although only the Kleinert technique was still with us. 1975, Duran and Hauser introduced entirely passive mobilization, but this technique is very labor intensive with no particular advantages. It failed as an alternative to Kleinert traction, but has found a use as an add-on to the active regimes nowadays to improve the extremes of motion. In 1989, the surgeons in Belfast removed the rubber bands and actively moved the fingers in both directions after standard 2-strand repairs and running circumferential sutures. This was not entirely new, as the very earliest surgeons didn't use rubber bands, and many others had tried to get rid of the rubber bands during the 1950s and afterwards, but always using some change to stronger sutures for fear that greater forces would have to be resisted. This wish to be free of the rubber bands had been around for years because of the problem you see on the right arising from the flexed resting position of the PIP joints in Kleinert traction. There had also always been doubts as to whether less intelligent patients ever actually used the rubber bands to flex the fingers or simply were flexing them with the repaired flexor tendons. Although Belfast themselves reported a higher rupture rate than the current Kleinert studies of the time, they quickly followed papers, mostly from the UK, with good and excellent results and rupture rates similar to those of the various Kleinert series, making this an acceptable alternative to Kleinert traction, and an argument over which is the best has largely vanished. And early active motion is where things are at present in respect of rehabilitation. A few modifications, which you see here, are being used by different units, although by no means universally. So far, I've only considered avoiding rupture as the goal of immediate suture and mobilization, but of course, a perfect range of motion is the ultimate goal. In 1994, Silverskåld and May in Sweden, although still with a 2% rupture rate, recorded the best results in civilian practice at that time, not only using their stronger circumferential suture, but using a clever mixture of the three rehabilitation regimes. The current St Andrews Chelmsford regime in my unit, as well as using the splint you see here to encourage PIP extension at night, is pretty much the same as the Silver Scold May regime, but without rubber bands. And with some unit-to-unit variation of the splint design and angles, and the way the rehabilitation is taken forward over the first 5 weeks to avoid rupture, this is where rehab is worldwide at the present. This is the most recent change of interest. Since 1940, treatment of the sheath on completion of flexor repairs was determined by interpretation of the tendon healing research at the time. And we've moved from radical sheath removal when we thought external adhesions were needed to bring in the nutritional needs to heal the tendon, through obsessive sheath closure in the 1970 to 1990 era, when we thought synovial fluid was needed to heal the tendon, to simply laying the sheath back after repairing the tendons, as we now believe tendon healing is mainly by growth of vessels along the outer aspect of the tendon to the repair site. During the Lundberg era, many authors began to doubt the wisdom of the Lister-Leuvel near mania for complete closure of the sheath. So now most of us, excepting a few Louisville trainees of the generation before me, who are now mostly gone, simply lay the sheath back after repairing the tendon. Despite tweaking immediate repair and immediate mobilization, we still had the same problems. And this is when various people started looking more carefully at the sheath, or more specifically at the pulleys. Going back a bit historically, there have been various ways described in different circumstances to tackle the dilemma of the tendons or the repairs being too large for the sheath. 40 years ago, Kleinert and Verdun said it was preferable to repair both flexor tendons at primary surgery, and so we all went on repairing both flexor tendons under nearly every circumstance. Although in the 1970s, Boyes, who was Bunnell's successor, had pointed out the problem of repairs sticking under the A2 pulley, which is the tightest part of the sheath. And more recently, Professor Tang showed better results when only the profundus was repaired for simple zone 2 divisions under the A2 pulley, particularly in situations in which there would be a lot of edema, such as you see on below at the bottom of the slide. And of course, the same is true in zone 2, where multiple tendons have been divided in the narrow confines of the carpal tunnel. In a secondary tenolysis, if the tendons are too swollen to move comfortably under the A2 pulley, I simply remove the FDS tendon. An alternative suggested by Kleinert was to remove half of the FDS. When a profundus tendon is pulled off or divided in zone 1 and drops back through the A4 pulley, then presents late, it may be too swollen to pass through the pulley. Even if we pull the tendon through by slow traction, we're likely to create a tenodesis and an unmoving DIP joint once the tendon swells postoperatively and locks under the A4 pulley. However, because the distal part of the profundus is double-barreled, the tendon can be halved, and the halved tendon passed through the pulley and reattached distally. And we do this rather than abandoning primary surgery for grafting with a palmaris tendon. And I think this is reasonable, as half a profundus tendon is thicker than the palmaris longus tendon from the same hand and is much easier to suture. If we retain the normal tendon numbers and size, something has to be done with the sheath. When adhesions were thought necessary to achieve tendon healing, surgeons routinely cut windows in the sheath. However, as you can see from this writing, they were also aware of the need to compensate for the bulk of their repairs, so they cut long windows to allow unimpeded tendon movement. Today, even if we don't completely close the sheath, there still remains the problem you see here. Various ways of dealing with the pulleys have been tried in the past. Stretching the pulleys with the urethral sounds doesn't work. and the rest of the pulley, not the repaired pulley, are doing the work after pulley lengthening, as you see on the right, as the small pulley flaps sutured with 5/0 or 6/0 nylon have very little strength. And finally, partial or sometimes complete division or venting of the pulleys. Juran and Hauser suggested that this if the repair was catching, and Strickland introduced the term venting. However, in the 1970s and 80s, Schneider was the only one of these authors to confess to having been forced to completely divide the A4 pulley, but only occasionally in difficult cases. And probably in company with many other trainees at the time, I kept very quiet in lectures by the great men, as I knew I had to cut the A4 pulley completely to get a full range of motion of the DIP joint after many of my repairs. It's taken a long time to make this procedure acceptable, because this entails interference with the A2 or the A4 pulley, the complete integrity of which was believed to be of great importance in maintaining the mechanical efficiency of the flexor system. Because when doing secondary flexor surgery, the minimum one needed to preserve to achieve flexing of the fingers with power was an A2 and an A4 pulley. This was then carried over into primary flexor surgery as a mandate to preserve these two pulleys at all costs. However, more recently, an increasing number of papers have shown that there's no absolute need to preserve the A2 or the A4 pulley so completely, or even at all, when most of the remainder of the sheath is intact. However, you could well ask, is it really necessary to vent the pulleys? And does it definitely not have a deleterious effect on ultimate function? First, is it necessary to vent the pulleys? In 1998, we carried out quite a large study of 126 fingers with tendon divisions between zone 1 and the distal edge of the A2 pulley, and 64% of them required some degree of venting to allow a full range of movement of the repair. The distal edge of the A2 pulley was vented in 10 fingers. All of these were tendons cut just distal to the A2 pulley with the fingers in full extension. And then the repair caught on the distal edge of the A2 pulley on flexing the finger. The A2 pulley is so long that in most cases, when dealing with injuries in the distal palm and at the very base of the finger, one can excise any third to half of it to repair the tendon, then allow the repair to have a free range of movement without affecting any pulley function. Where there is still a problem of gliding, there is current debate whether to not repair the FDS at all, repair half the FDS only, or cut the A2 completely, provided the rest of the sheath is intact. However, these are rare events, and the evidence to support cutting the A2 completely is still on the boil. It hasn't been decided whether this is acceptable. There isn't enough evidence in the literature. The other problem is the A4 pulley. After cuts around the PIP crease with the finger partly flexed, when the finger straightens, the profundus has to be repaired more distally. And the proximal part of the A4 pulley may need to be vented either, as you see in the top, to the right, to pass the distal half of the core suture, or to allow the repair to move distally and achieve full DIP extension, or often for a mixture of both reasons. Venting pulleys is likely to be more necessary with the larger sutures, whether circumferential or core or both. In fact, Tang now recommends something which was taboo in the 1980s. He believes that slight bunching of the core repair makes the repair stronger and gapping less likely, and the increase in size will be accommodated by the subsequent pulley venting. Proximal A4 venting is the common problem, as you see here. Very occasionally, the FTP division, when it is cut more proximally with flexed fingers, is beyond the A4 pulley. This is because the position of the A4 pulley on the little phalanx is variable. Next question, does venting definitely not have a deleterious effect on ultimate function? Well, this paper was the first of a series of papers during the last decade reporting routine complete division of the A4 pulley with no significant effect functionally. Complete venting of the A2, provided the rest of the sheath is intact, as I mentioned earlier, is in the melting pot of discussion at present. It's actually rarely necessary, but the literature evidence to support completely dividing the A2, even with the rest of the sheath intact, rather than repairing FDP only, is still lacking. Common sense dictates that completely cutting the A4 pulley will not cause significant bowstringing. If you try this experiment, extend your right index finger and grip the finger at the PIP joint between your left thumb and index finger so that the PIP can't flex. Now bend the DIP joint and look at it. If the A4 pulley was absent, you can see how little the flexor could bowstring at this level, because the distance across the flexor aspect of the DIP is so small. So reconstructing the A4 pulley is never necessary, and if it's done as illustrated in older textbooks, the pulley wrapped over the extensor tendon will create a tenodesis and prevent any DIP flexion at all. Distal bowstringing, as you see here, is very, very rare, and I believe only occurs when there's a complete absence of the sheath beyond the A2 pulley. This is a problem of secondary surgery, and it shouldn't arise in primary surgery, as we're taught to work through windows in the sheath, leaving most of the sheath intact. Recently, Professor Tang has suggested that we routinely test our flexor repairs before closing the fingers to see that the repair moves through a full range of movement without catching on the pulley at either end of its range of motion. Essentially, we're back where we started with Mason in 1940 and Verdun a little later. A major change has occurred in our practice in respect of much more primary surgery and less secondary surgery. Although cases always will come to us late and need secondary surgery, by better primary management and a few tricks, we can do less secondary surgery, and I plan to discuss this in detail in a later lecture. In terms of assessment of our results, little has changed since 1989. For decades, results of primary surgery were assessed using the American Society TAM, or Total Active Motion regime, which measured the combined range of motion of the MCP, the PIP, and DIP of a finger after the repair. Strickland in the States and Buck-Gramko in Germany removed the MCP measurements from assessment of finger repairs in Zone 2 and Zone 1, as the MCP range of motion should be normal in these, so including them artificially improves the results. And currently, the German-speaking nations still use the Buck-Gramko assessment, and the rest of the world uses Strickland's original assessment for Zone 2 injuries. In 2000, we had described an assessment for Zone 1 injuries, which only considers the DIP, as the PIP should be normal. In assessing secondary surgery, the MCP has to be included as the tendon graft crosses all three joints. So these cases are assessed with the TAM system. This is very much less generous to the results than the old boys assessment of 1970. But the TAM assessment of secondary surgery makes realistic comparison of the results of primary and secondary surgery more realistic. In a study 20 years ago, we looked at the etiology of the ruptures in our unit. This group included some who messed things up through no fault of their own, and this may be improved by simple measures such as you see at the bottom of this slide on the left. However, the group will include a number who simply do not like and ignore rules, and these are the real problem. And in civilian practice, we have few direct weapons to use against these patients, although they can sometimes be moved up the learning curve by psychological manipulation and time spent, usually better done by therapists than surgeons in my experience. Rehabilitation doesn't happen by chance and doesn't happen without therapists. They are essential, and good therapists make the difference between lots of complications and good results after all hand surgery, but particularly after flexor tendon repair. We not only need to do this good policeman, bad policeman act in the wards, but need politically to support the creation of more therapists when administrators see removing them as an easy way to reduce hospital salary costs. To date, this has all been about bathing the tendons in a chemical, and the benefits of these drugs remain unproven and experimental, and worrying because surgeons worry that the drugs will do the same to the repairs and to the skin as they do to the adhesions. However, other modalities of controlling adhesions are on the horizon. Recent research has identified that growth factors play a critical role in the biochemical pathways of healing an injured tendon. With this realization comes the possibility of manipulating healing through these growth factors, either by direct application to the tendons or through gene transfer techniques. Flexor tendon surgery has come some way in my working lifetime, but this is not entirely a solved problem, and it won't stand still through your working lives. New ideas keep appearing. This is a recent extension of our halving of the distal FDP to get through the A4 pulley. I first came across this when I was asked to review a paper in India a good many years ago, and as you see in the slide, it disappeared but has resurfaced recently in France. This is, if you split the FDP of a normal finger all the way to the palm, it can be used to motor an adjacent finger, avoiding using a tendon graft. It may also be the answer to primary suture of little finger tendon divisions, which have by far the worst results of repairs in all the fingers, with more stuck tendons and more ruptures. This technique moves the goalposts from tendon sutures within the sheath to one distal tendon suture into the terminal phalanx, which can be made stronger and does not have to glide, of course. Another new idea. Use of vascularized flexor tendon grafts from the distal forearm taken up into the fingers on a distally based ulnar artery pedicle. This was first suggested and done by Guimbertu and his colleagues in Bordeaux, but not repeated elsewhere until this paper appeared in 2015 from Spain, confirming good results with this one-stage procedure. Successful primary flexor tendon surgery is a complicated problem. It has required the combined thinking of many surgeons in many countries to get so far as it has today. And the baton now goes to you, the audience. Thank you very much for your attention, and I'd be happy to take questions.
Thank you so much, Mr. Elliott. That was incredible. It was a history of tendon surgery and tendon repair, and we are most grateful for you giving this amazing talk. We have over 350 attendees at the moment, and we will start with some questions if you're happy. So we have a question about the two-strand repair. So some units are still seem to be doing two-strand repairs, especially in the publication series that you showed. Do you feel there is a role for two-strand repairs when there's such good in vitro and also clinical data to show that 4 or 6 strands are superior?
Can you hear me?
Yeah.
Am I now on? Yeah. I think that if you do a circumferential suture, then of course the two-strand repair is not a 15 Newton repair, it's a 35 Newton repair. And that is probably enough. And I think the results of some studies that's why they have reasonable results. However, I think to do a 4-strand or a 6-strand repair is as easy. And for the reasons particularly the ones I showed, I mean, a 4-strand repair, as demonstrated by David Evans, was simply to put two two-strand repairs at 90 degrees, and it takes very little more time. Sugi sutures are more expensive, but once you've learned the technique, the 3 sugis, or the Tang idea of doing 3 of them, is very fast. And so I think I think we've moved on. I think really that we might as well use 4 and 6 strands. I don't think there's a huge amount of evidence. And I think if Jason Wong was there, we could ask what's happened to the research into tenocytes moving away from the sutures. I mean, has this gone any further? Is it a serious problem? But it's just one bit of research that kind of came on the horizon.